Hello, everyone. Welcome to the Agency for Healthcare Research and Quality's National Health IT Web Conference on Reducing Provider Burden Through Better Health IT Design. Although a few people are still logging in, we are going to go ahead and get started on time. My name is Brian Kim, and I'll be moderating this webinar. I currently serve as a health scientist in the Division of Health IT, Center for Evidence and Practice Improvement at AHRQ. Here's the agenda for today's webinar. Please note that we are recording this webinar, and the recording will be available via AHRQ Health IT YouTube channel in about 2 weeks. Copies of the PowerPoint slides were emailed to each of you earlier this morning and available for download as you logged in today. We will also be sending them to participants via email following the webinar. We are pleased to have today an esteemed group of presenters. We'll provide a more detailed introduction before each presentation starts, but the presenters include Dr. Pascale Carayon from the University of Wisconsin-Madison College of Engineering, Dr. Zia Agha from West Health, and Dr. Lukasz Mazur from the University of North Carolina, Chapel Hill School of Medicine. This webinar event is accredited by the Professional Education Services Group, also known as PESG. And for those of you who are interested in receiving continuing education credit for participating in this activity, information about how to claim your credit will be presented at the end of the presentation. Information will also be emailed to you after this webinar. For the purposes of accreditation, let me note that neither AHRQ, TISTA, RTI, PESG, nor Drs. Carayon, Agha, and Mazur have any financial interest to disclose. Lastly, please note that no commercial support was received for the development of this learning activity. Just a brief note about questions. We have reserved time at the end of the presentations to address participant questions. However, during the presentations, feel free to submit questions that you have for the presenters using the Q&A panel located on the right of the PowerPoint slides. As a reminder, all participants are in listen mode only, so to ask questions, you will need to use the Q&A panel. This slide shows the learning activities objectives for today's webinar. By the end of this presentation, you should be able to identify the cognitive and teamwork involved in venous thromboembolism, also known as VTE, prophylaxis, and the socio-technical system design requirements that support collaborative VTE prophylaxis teamwork. You'll also be able to describe methods for capturing and analyzing electronic health record use, also known as EHR, for providing a comprehensive assessment of usability, clinical workflow, physician-patient communication, cognitive load, and user satisfaction in 2 distinct outpatient settings. And lastly, explain an evaluation to assess provider mental workload and performance on abnormal test result follow-up in both the standard and enhanced EHR environment that includes results tracking functionality. And now, it is my pleasure to introduce our first presenter, Dr. Pascale Carayon. Dr. Carayon is a Procter & Gamble Bascom Professor in Total Quality in the Department of Industrial and Systems Engineering and the founding director of the Wisconsin Institute of Healthcare Systems Engineering at the University of Wisconsin-Madison. She has developed human factors and systems engineering methods and the Systems Engineering Initiative for Patient Safety Model, also known as SEPS, to improve patient safety and health information technologies in complex healthcare settings. The Joint Commission and the National Quality Forum have recognized her contributions to patient safety, and in 2016 presented to her the John M. Eisenberg Patient Safety and Quality Award for Individual Achievement. And now, it is my pleasure to turn the control over to Dr. Carayon.
Thank you, Brian. In this presentation, I will explain how we went about identifying the cognitive and teamwork involved in VTE prophylaxis and how we used all of this data to come up with socio-technical system design requirement. With the project that we'll be talking about, we wanted to go beyond SIT for specific tasks or specific groups of users and really think about health information technology for teams and to support care processes. And the particular care process that we studied in our project is VTE prophylaxis. The project is funded by AHRQ and has two main components. One component looking at health information technology for VTE prophylaxis for hospitalized patients, and another component looking at the diagnosis of VTE in the emergency room. I will be talking about the first component of the project. If you're interested in learning more about the project and the second component, feel free to visit the website of our project that's listed on that slide. The project involved a number of faculty, researchers, and students from three different institutions that represented many different domains of expertise, including engineering, human factors engineering, systems engineering, as well as a number of clinical domains. We know that VTE, which is comprised of deep vein thrombosis and pulmonary embolism, is a patient safety problem. It is actually one of the healthcare-associated complications that is tracked and targeted by many organizations, including CMS and AHRQ. The American College of Chest Physicians and the American College of Physicians have developed a number of solutions, and those solutions have included guidelines for VTE prophylaxis. And very often those guidelines include an element of understanding the risk of the patient. What is the VTE risk of that patient? And those things are what we call risk assessment algorithms that are then embedded in the EHR in the form of clinical decision support or CDS. However, the impact of these solutions has been somewhat limited, and sometimes the solutions themselves may not be optimal. For instance, we know that designing and implementing health information technology can be difficult. Figuring out how to design technologies that are both usable and useful is challenging. And at a broader level, at a broader system level, ensuring that the technology is integrated in the clinical workflow is also a major challenge. With regard to VTE prophylaxis, more specifically, a lot of the solutions have focused on what happens when the patient is admitted at the hospital. That decision about whether to order VTE prophylaxis for the patient is based on those risk assessment algorithms. Those decisions at admission are important, but we know that we need to consider the entire hospital stay. When patients have missed doses of VTE prophylaxis, they are actually at higher risk of VTE. And when we think about what happens to the patient during the entire stay at the hospital, it is therefore important to think about all of the people involved in that process, the physicians, pharmacists, nurses, and so on. This is why we think that understanding VTE prophylaxis from a socio-technical systems viewpoint is important. Therefore, in our project, we use our model, the SIPS model of PONC system and patient safety that defines different elements of the system. And those are shown on that slide as the yellow boxes, thinking about who's involved in the process, what technology and tools they're using, what they're doing, what's the physical environment and the organization like. In our particular project, the process of interest is VTE prophylaxis, which includes a number of different steps, not only admission of the patient in the hospital, but also what happens later on. Does the prophylaxis need to be interrupted because, for instance, the patient may need a particular surgical procedure? If the prophylaxis is interrupted, does it need to be reinitiated? If prophylaxis for some reason was not ordered upon admission, does prophylaxis need to be initiated? And we also know that transfer of the patient in different units of the hospital is also an important time to review VTE prophylaxis. In our study, we use a multiple case study design that involved a total of 11 cases spread in 4 different hospitals. Those 4 hospitals represented a large variety. For instance, there was one small community hospital and then one very large academic medical center. The 11 cases, as shown as purple boxes on that slide, represent different services or patient populations, have different organizations, different staffing model. Therefore, it provided us for a variety of contexts in which we studied the prophylaxis process. Like in all of our projects, we use a variety of data collection methods to analyze the VTE prophylaxis process and its 5 phases. We conducted a survey of about 1,000 attendings, residents, PAs, and NPs, pharmacists, and nurses. We also performed some observations, looking specifically at what happens during morning rounds and trying to capture VTE-related activities. We finally conducted a number of interviews and focus groups using our SIPS model to understand what the process is like and whether there are system barriers and facilitators to that process of VTE prophylaxis. On that slide, you can see a picture of a focus group we conducted at a hospital with internal medicine residents. I'm going to show you how we used 3 types of data analysis to come up with socio-technical design considerations. But before I do that, I wanted to tell you about the overall participatory human-centered design methodology that we used. Our objective was to define design consideration for the technology that can support cognitive and teamwork in VTE prophylaxis. But it's not just the technology. We're looking at it from a socio-technical system viewpoint. It's also the other elements of the system that we needed to think about and consider. In our participatory process, we involved clinical team members and many local and national experts and used a variety of methods and concepts from design thinking. So that slide actually shows you the end product. We ended up with a list of 22 specific design considerations that focus on the interruption and reinitiation phases of VTE prophylaxis. Those 22 specific design considerations were grouped in 13 categories that are listed on that slide. I'm going to show you how we use some of our data to come up with some of these design considerations. So, oops, sorry, I went the wrong way. So let me start with the survey. So the survey of about 1,000 nurses, pharmacists, and physicians involved a number of different questions, including the question that is listed on that slide: who is best able to provide daily assessment of patient need for VTE prophylaxis? On that slide, you see on the x-axis the different groups of people who responded to the survey: nurses in red, pharmacists in green, and physicians in blue. And each one of them chose one of many different roles that they thought was best able to do that daily assessment. And those roles are listed on the y-axis. So, for instance, 20% of the nurses chose attending physicians as the group best able to provide daily assessment. They also chose residents. 24% of them chose that group of individuals. But 29% of the nurses who responded to the survey thought that nurses were actually best able to provide daily assessment of patient need for VTE prophylaxis. As you can see on that slide, there is a lot of variation. Variation not only comparing the 3 different groups of respondents, the red nurses, green pharmacists, and blue physicians, but also a lot of variation within a group, which really highlights the important need to reduce role ambiguity. So really figuring out how we can clarify roles, who's doing what on the team, how can we come up with team configurations that actually clarify the responsibilities of the team members. We also need to take advantage of the team when team members are that second pair of eyes and help in identifying issues with VTE prophylaxis. So that balance between role clarity and error recovery resilience is actually shown at the bottom of that slide. And then can we think about technology, for instance, automation, that can help in that process? And for instance, monitoring or suggesting a need to interrupt or reinitiate VTE prophylaxis. The second analysis, and I'm going to go through that one rather quickly. If you're interested in it, my colleague, Dr. Ann Hunt, has published a paper that talks about that particular role network analysis. A very interesting method that allows us to identify the different members of the team. The bubbles on that graph are the different roles, in that case, APPs, residents, pharmacists, and so on. We also can look at what they do, their individual activities, what they do together, the team interaction, the different technologies that they use. And sometimes we can actually also show one of the organizational elements, for instance, activities that are performed during multidisciplinary rounds. So we're able to represent the different elements of the system in a role network analysis. We actually constructed 61 of those role networks, and they were created because, remember, we have 11 different services or cases that we looked at, and there were many different stages of the process. We use that data to then highlight the need to support teamwork, in particular the communication between the attending physician and the non-attending physician. The role network analysis also highlighted the importance of many different roles and the need for everybody to be able to speak up, so that idea of transparent, open organizational culture, while at the same time figuring out what is the structure that can be helpful to support team discussion and bringing things up to the team, for instance, structured multidisciplinary rounds, checklists, or reminders in the EHR. The biggest part of the data analysis was to conduct that cross-case analysis. Remember that we have a total of 11 cases, 11 services. We combine all of our data in those what we call case report, and each one of them had about 11 to 25 pages and included all of the sections that are listed here: the context, data on VTE process and outcomes, some survey data about perceptions and attitudes toward VTE prophylaxis, the role networks that I just talked about, the roles, and I show you some of that data, some of the observation data on VTE-related team interaction, as well as survey data on perceived barriers and possible solutions. We then used all of this data, and remember, 11 cases, 11 case study report. That's about 150 to 200 pages of data. So we needed a mechanism to make sense of those data. And the method we chose is called cross-case analysis table. In a cross-case analysis table, each column is a case. So I'm showing you here in that table a small piece of the cross-case analysis table. So there were 11 columns, and then different section of the table, each one representing a different section of the report. So contextual information then was summarized and plugged into that cross-case analysis. That process is known in design thinking as that divergence-convergence process, so really taking a lot of data and trying to make sense of it. The other part of making sense of that data was to use different perspectives. So the way we went about it is actually summarized in that box. We looked at different rows of the table. Sometimes we looked at different columns of the table. So for instance, we compared and contrasted the 3 cases in critical care medicine. We compared and contrasted the 2 cases of critical care services, and we had 4 cases that represented hospitalists, and we compared those. So a lot of different ways of looking at that cross-case analysis table. And that process then led us to that final list of 22 specific design considerations combined in those 13 categories. And each category has about 1 to 4 specific design considerations. The really important thing to us is looking at it from a socio-technical viewpoint. We wanted to make sure that our categories of design considerations and the specific considerations actually represented the entire system. And that's actually what you see. The first one of the patient journey is actually represented here in the process. Some of the design considerations in that category included, well, what's the status of the prophylaxis order? What is the status of the patient with regard to risks and benefits and contraindication? We also have 2 categories of design consideration that represent the task element in the system, including clinical appropriateness and workload. We know workload is a major issue, and actually the next 2 presentations will also address that topic. So the solution that we design cannot add workload to a already busy system. Very important concept. We also had a number of design considerations that tackle organizational issues, and I've talked about some of them early in my presentation. The technology was also represented in our list of design considerations. So not only access to the information, but also physical access. Can I get physical access to the technology? And of course, that is related to the environment. Is there space for the technology where I need it? And is there space, so that's the physical environment, for the entire team to be together and communicate? The person element was also represented in our design considerations. Education of nurses and physicians with regard to appropriate ordering of VTE prophylaxis, as well as patient education. Our survey actually shows that a large number of nurses in particular mention patient discomfort from the injection as a major barrier. And finally, the feedback loop, really critically important in a systems perspective. So some of our design considerations include building a dashboard for the unit with data at the patient level as well as the unit level. So just-in-time information about what's happening with patients in my unit, as well as another more long-term feedback on performance. Because our design was a multiple case study design, we are able also to consider context, and we collected data from many different contexts, and we're able to show that, of course, context matters. So, for instance, built-in redundancy and error recovery is very dependent on the context. In critical care services, there is a routine of morning bedside rounds with multidisciplinary teams. Those teams very often bring up issues of VTE prophylaxis. That structure is typically not a structure that occurs in many other services. So we need to figure out what is the redundancy error recovery mechanisms that we're going to use when that structure doesn't exist in a particular context. The physical environment, of course, varies a lot between hospitals and between units. Because we use that socio-technical system perspective with our SIPS model, we feel that we were able to really understand the entire system and capture the different elements of the system as well as the feedback loop in our design considerations. The process was human-centered, human factors design process with heavy participations at the local level as well as local and national experts. The process involved many different iterations that use the benefits of multiple disciplines. And of course, a major strength of our study is the ability to look at context and multiple contexts. In conclusion, I actually wanted to leave you with a thought about those design considerations, the 13 categories, were created looking at a particular process, VTE prophylaxis for hospitalized patients. And I guess the question that I have is, can we think about those socio-technical design considerations and apply them to many other processes? So at this point in time, I'm going to pass the presentation back to Brian Kim.
Thank you, Dr. Carayon. As a reminder, we'll be taking questions after all three presentations, so please submit any questions you have for Dr. Carayon using the Q&A panel. So let's move on to our second presentation of this webinar, which is being led by Dr. Zia Agha. Dr. Agha serves as a physician leader for West Health, which includes the West Health Institute, the Gary and Mary West Health Policy Center, and the Gary and Mary West Foundation, ensuring its research portfolio and its initiatives are translated into clinical practice, policy reform, and scalable innovations that will allow seniors to successfully age in place. Dr. Agha leads the development and execution of clinical research activities and brings a comprehensive understanding of the evolving field of clinical informatics, such as clinical information systems, telehealth, and data science. Dr. Agha joined the West Health Institute in 2014. Prior to joining West Health, he was a director for the Health Services Research and Development Division at the VA San Diego Healthcare System and professor of medicine at the University of California, San Diego. He currently holds an appointment as part-time professor at UCSD. And now I would like to turn the control over to Dr. Agha.
Thank you so much, Brian, for the introduction. Okay, so my talk is going to focus on our efforts to study EHR usability within the context of clinical workflow, and then some efforts around inferring how does the usability in clinical workflow integrate with cognitive workload. This is work that is supported by AHRQ, and in full disclosure, I was at that point a faculty at the VA and UCSD when this work was conducted. Subsequently, I have moved on. If you think about studies and methodologies for evaluating EHR usability, the most common ones that come to mind are either ethnographic studies of observations or laboratory studies. We wanted to conduct a study that used more of a real-world context, but tools and technologies that are typically used in more of a laboratory setting. So it's somewhat of a hybrid approach, which comes with its own set of challenges that I would like to point out as we go through this research. Okay, let's start with our study aims. Our first aim was to sort of measure and compare EMR usage patterns. And this was important to us in able to get the granular data that could then inform what's happening in terms of workload, workflow, interactions with the patient, and cognitive work. We propose to do this during real clinical visits by using various streams of data that I will detail how we captured. A second and related aim was to compare the clinical workflow and the communication patterns between a clinician and the patient. We all know that clinical work and EMR work happens simultaneously in most practices, although there are some practices where physicians will enter notes at the end of the visit. At least in these two practices that we were working in, these two activities were happening simultaneously. We also know that the complexity of the clinical work often dictates what's happening in the EMR and decision-making. And so we need to account for those two activities somewhat simultaneously. And so we propose to measure clinical workflow and then associate it with communication efforts and also the discrete sort of EHR activities that we are able to record and compare. In terms of the cognitive load, it's clear that the role of the EHR and the human-computer interaction does impose some administrative and cognitive burden. However, this burden has not been quantified, and more importantly, it has not been quantified in the context of other activities. So this effort was very much targeted at, one, measuring the cognitive load, and then understanding what is the association of cognitive load with some of the other activities that we are going to measure. It's obvious that there are many other elements that are needed to be taken into account, which were either not directly captured in the study, but we tried to supplement those by doing physician interviews. So for instance, the complexity of a patient, interpersonal relationships, the fact that you're running late in clinic, all of those things can change your cognitive load perceptions, and we tried to infer those through qualitative measures. And then sort of the highest level goal was to look at the three different things I just talked about and try to associate them together. And then a second goal was to compare across sites and across specialties. We know that the clinical work and the EHR work is very much an organizational factor. We heard that in the previous presentation, that looking at the organizational culture, expectations, policies and practices all impact how physicians interact with the EHR and with their patients. And this was an effort to sort of compare two organizations that are very different in terms of their organization of the clinical work and policies and practices, but of course also have different EHRs, so giving us an opportunity to do some compare and contrast. We also were cognizant that different specialties, primary care versus subspecialists, have slightly different workflows. Let's begin at the highest level of comparing the two sites and how their EHRs are implemented. The two sites we conducted the study was UCSD and the VA San Diego. UCSD is a large academic medical center, and we did the study in their primary care practice. Their patient demographics are like most academic medical centers, so there's an equal number of male and female patients. On the VA side, it's predominantly male veterans who are participating in the study. At UCSD, they schedule their follow-up and new patients for 20 and 40-minute visits or shorter than that. And at the VA San Diego, the visit lengths are longer, 30 and 60 minutes. The two EMRs, Epic is used at UCSD, and the Computerized Patient Record System, or CPRS Vista, is used at the VA. There were certain nuances in the setup of the room and the computers and how the technology was deployed. I would sort of point out the most important ones. At UCSD, they used a single monitor setup but Epic does allow you to have multiple windows open on that single monitor, and you can interact with them. On the CPRS side, there were dual monitors present in 35% of the visits, but Epic does not allow you to fully take use of these dual monitors, and you cannot interact with multiple windows at the same time, which has implications for task switching and navigation. UCSD and Epic also allow you to do some real-time care coordination activities versus those activities are done offline in the VA system. The general structure is very similar across the two EMRs, other than the use of smart phrases in Epic, where you're able to use smart phrases and more pull-down windows and selection items, especially on the documentation side, versus on the VA side, most note entry is free text or template-driven. Just to give you a sense of the distribution of patients and physicians, around 15 physicians and 116 patients from UCSD. These are all patients of these physicians that we enrolled in the study. And on the VA side, 17 physicians and 107 patients. Somewhat similar mix, around 7 to 8 patients per physician we studied. The subspecialties, gastroenterology, pulmonology, cardiology, were chosen to give us a broad sampling of different workflows. So I do want to spend some time on our data collection approach. And there were two sets of instruments that we sort of break them down into. The primary instruments that we used for the study, which really relied on video cameras in the room that allowed us to capture the clinical workflow and the verbal interaction and the nonverbal interaction in the room. And then a usability software, we used Moray, which was installed on all the computers in the study that allowed us to capture mouse and keyboard activity, but also a full recording of the EHR screen. These two streams were time-stamped and synced subsequently for data analysis. For both of these two streams of data, most of the coding happens by human coders. We did instrument some automation within the secondary instruments. One of our goals was to see, could we use body tracking, aka a Connect camera, to at least look at some gross gaze direction and movement activity. And we deployed an eye tracking system to be able to track where the physician is looking within the EMR, specifically when they are reviewing notes and looking at orders and data. This slide shows a little bit of sort of the different signals and the workflow process. It's important to tell you all that the data is collected within the context of the clinical visit. So we start collecting data once the patient and physician are together in the room, and we stop collecting data once that encounter ends. We are very limited in inferring what happens outside of the visit. Those types of information were either collected by looking at logs of the EHR in a retrospective fashion or by talking to providers. But from this rich data stream and post-visit surveys for cognitive workload, we use the task load index. We are able to create a snapshot of what happens during the clinical encounter from multiple perspectives. Since most of the data was done by human coding, we had to develop our own proprietary coding algorithm. We used a handful of set of visits to start to develop and grow the coding algorithm and test it. And once it was implemented, we did do double sampling across visits to look at intercoder reliability. And for most measurements, we found good agreement on the coded activities, whether it was activities such as mouse clicks or verbal discourse. On the time-resolved elements where you're trying to understand the timing between two events, the resolution drops, and the agreement was only 0.64%. And often that is not a factor of differences in the coding algorithm. It's more a factor of our ability to align the timelines post-hoc. And so you can imagine if the audio coding is off by a few seconds between two coders, that few second delay is going to show up in the inter-rater reliability codings. One way to compare or study EHR functional activities is to count mouse clicks, and this work has been done by us and others and described in numerous papers. At the highest level, this gives you some idea around the burden of the user interface that EHRs present, given that we are, highly dependent on using the mouse and the keyboard to enter information. Of note, while dictation was available at both sites, very few providers use dictation to navigate within the EHR. If they do use dictation, it's mostly just to dictate text into a free text field. So if you look at the common areas within the EHR where people spend most of their time, by no surprise, notes and orders account for almost 70% of activity, both in terms of counts of mouse clicks and in terms of timing. We did see some differences between the UCSD and the VA in terms of the amount of time or the percentage of time spent in notes and orders, and it seems like there is more time on the VA side compared to the UCSD side. But the bottom line is, in both instances, many mouse clicks and many minutes are spent engaging with the EHR doing these low-level activities. Here's another way to display this data in a more visual fashion to also sort of impress upon you that the EHR activity that you capture through mouse clicks and key clicks also reflects in the nonverbal activities of the provider, especially if you code those nonverbal activities along the axis of if the provider is looking at the EMR, looking at the patient, or doing physical exam, or engaging with clinical staff. These two panels show the same visit. On the left side, you have data on the amount of work that went into putting together notes, orders, labs, meds, and so forth for a set of visits. Each line is one visit for a provider. And on the right-hand side is for that visit the time that was spent looking at the EHR or the computer screen versus spent directly eye contact with the patient. Of notice, you can see that these two correlate very well, but we also see that there is variation across visits for providers. And these patterns can be studied in much more detail, as I will tell you later. If you looked at the computerized patient order entry frequency and burden and time at task, you can again compare the number of clicks needed per order placed. So sort of an efficiency measure from a usability perspective. And you can also measure the time at task in doing these orders. One thing that very quickly jumps out is that physicians are very efficient in the number of mouse clicks they can navigate within a small amount of time. If you look at consults, in less than a minute, 49 seconds on general per consult order, and that's 11 mouse clicks. If we look at things like medication orders, 38 seconds to order one medication, and it requires 10 mouse clicks to do that. So one thing we have observed during both our interviews and looking at this data is that physicians have become very adept at using these interfaces and almost expect that it's going to take them that many clicks to execute a single order. What becomes interesting is that when there are many orders and consults within each visit, the number of mouse clicks can reach into the hundreds. And most physicians aren't aware of this. When we show them during their interviews their own data, they were very surprised by the number of mouse clicks that they were engaging in to conduct their work. Here's again a high-level example of showing you some of the differences between the two sites and the two specialties that we studied. What's important to look at is what we call sort of gaze dominance or sort of verbal dominance. So if you look at the blue bar, that is the physician interacting with the EMR, and the green bars are the physician's interactions with the patient, and this is along a timeline. So for the VA San Diego primary care patients, for the average visit of around 18 minutes, we saw that almost half the time, which is approximately 8 to 9 minutes, was spent interacting with the EMR, and then the rest of the time was split between interacting with the patient, conducting a physical exam, and then doing some paper documentation. We see the specialty visits were longer, but a similar pattern of interaction between EMR and patient. And we saw the same sort of relative distribution of time and effort towards the EMR and the patient within the UCSD environment. If you start to look at the individual providers, so these are individual providers, D31, D21, D26, you can see that there is variation between both length of visits and the ratio of activities. So for instance, D31 is a provider who has short visits, spends a lot of time on the computer, very little time, very little green bar there with the patient. On the other hand, D20 has much longer visits, spends more time with the patient, as denoted by the green bar, and has still a significant amount of time that is spent on the EMRs. So it's true. This data shows that there are different patterns that physicians have adapted to, but there is some issues around efficiency here. Clearly, the provider who is spending more time is addressing more needs or has more time to talk to the patients, but is that the most efficient use of their time versus providers who are taking shorter visits is a question. I'm going to spend a few minutes talking about this slide and then jump into the task load index data. This is a very busy slide which shows you all of our data streams, the mouse click paths for one visit, the tab sequence of the mouse clicks by the different types of activities, the eye tracking activities, the nonverbal behaviors on the timeline, and so on and so forth. The point that I want to show here is that by having this data all time aligned, you can select certain segments of the visit to do further interrogations. So you could say, show me a period in the visit when the doctor is not engaged with the EMR, but is engaged with the patient, let's say this segment, and tell me what's happening on the eye tracking channels and the mouse tap channels. So this technique allows us to do interrogations of data across channels. Here's the timeline of navigation effort in terms of changing tabs. Each color is a different activity. And what you will notice here is that physicians have lots and lots of transitions between notes, orders, meds. And these tab transitions have been, at least when we talk to physicians, have been a big source of cognitive load, issues with forgetting to do things because they're constantly switching their mental frame and going from one activity to the other within the EMR, and then, of course, within their interaction with the patients. For the cognitive load ratings, if you were to rank order them, it seems like the effort rating was the most important one, and it showed up in the top 5, and then negative performance. And effort was most highly associated with visit length, but then EHR tab transition is the point that I was making earlier. Mouse clicks was also an important part, and the amount of time spent on the EHR, sort of looking at the EMR, was also related with the effort rating. We did have the opportunity to look at gender. We saw some signal here where the female providers had lower effort ratings for mental demand, physical demand, time pressure. This is significantly different from the male physicians. We don't really know how to explain this, but worthwhile noting. Maybe move on to this slide where we can show you that even within the effort scale or the use of task load index, it does not correlate always with some of our performance measures. This slide shows good correlation with visit length and effort. As visit length gets longer, effort is more. And then EHR tab transitions and effort. As there are more tab transitions, more switching of tabs, effort is higher. On the other hand, if you look at the Charlson Comorbidity Index, a measure of complexity of the visit, it does not relate to performance. And if you look at EHR tab transitions, again, it does not relate to the performance during the visit. Again, I think I want to highlight here that some of these associations are very complex and are not single order associations between a task within the EHR and workload. In summary, we were able to demonstrate or test a novel approach of collecting and combining data from multiple streams. We did see high variation in activity across sites for somewhat similar visits and patient types. We saw similar navigation patterns across two very different EHR systems with minor differences within notes and orders. It's very clear that the burden or the user interface burden was high at both sites, both in terms of the effort reporting, but also in terms of the mouse clicks and time taken to complete tasks. While this was a very high-level association study, one could do more granular studies where you could, like in our previous presentation, study a single disease or a single type of workflow using a similar approach. In terms of the cognitive workload, it's clear to us that while the EHR plays an important role, other aspects of the visit, the environment, the interpersonal relationships between the physician and the patient, what's happening outside of the clinic, all probably plays an important role in how physicians feel workload as they're performing their daily tasks. Obviously, this work was a team effort. These are all the colleagues, both at the UCSD and VA site in San Diego, but also colleagues from other universities like University of Michigan, University of Utah, that participated in the study. I'd like to thank them all. And I'm going to open the floor now for our next presenter.
Thank you, Dr. Agha. As a reminder, please submit any questions you have for Dr. Agha using the Q&A panel. Let's move on to our last presentation of this webinar, which is being led by Dr. Lukasz Mazur. Dr. Mazur earned his BS, MS, and Ph.D. in Industrial and Management Engineering from Montana State University. He is an assistant professor in the UNC Chapel Hill School of Library and Information Science and the Radiation Oncology Department in the School of Medicine. His research interests include healthcare engineering management as it pertains to the continuous quality and patient safety efforts in healthcare and human factor engineering with a focus on workload and individual performance during healthcare providers' interactions with health information technology. And now, I would like to turn the control over to Dr. Mazur.
Welcome, everybody. Thank you for a great introduction. And would like to say that I was very stimulated by the presentations by Dr. Carayon and Dr. Agha. Thank you for those great presentations. A few acknowledgments before I begin. I would like to acknowledge the project officer, Steve Bernstein, for funding our study and helping us throughout this process. We completed the study last December. I would also like to acknowledge my co-PIs, Dr. Carlton Moore and Dr. Lawrence Marks. Especially, really would like to acknowledge Carlton for his conceptual work with us at the beginning of the study, making sure that we can design the scenarios and experiments that reflect the reality in a real clinical environment. Also, I would like to acknowledge Dr. Pratima Mosley She works in our laboratory, she manages it, and she spent endless hours conducting the experiments with participants, and she is our expert on processing the physiological data that we've collected from eye tracking and EEG. Also, our UNC EPIC consultant, Amy Colchio, she worked with us to design our experiments in EPIC Playgrounds, a platform where we conducted the experiments. And finally, would like to also acknowledge Dr. Donald Spencer, Professor and Vice President and Chief Medical Informatics Officer at UNC Healthcare, for allowing us and helping us create the infrastructure within the School of Medicine to conduct this study. This is an honor to be a part of this presentation, and I really would like to thank AHRQ for this great opportunity. So a few points before I dive into our study. First, there's evidence that we can improve patient safety with the health IT, and I believe we have to widely embrace these concepts. There's a long way for us to make the interactions of providers with health IT optimal, but we are on the right path. To some degree, we need to better understand the risks that are associated currently in the current systems with the interactions in the complex systems, and I believe Dr. Carayon and Agha have already exposed some of these issues to us. And as we've heard from Dr. Agha, the interactions overall are quite click-heavy, right? So let's take an example that in a 10-hour shift, seeing on average about 2 to 3 patients per hour, a provider has to conduct about 4,000 mouse clicks to complete the work. So the question arises is how can we expect that the provider's cognitive control is under control, and we would expect the providers to not commit errors during such interactions. Unfortunately, some of these errors that are happening during these interactions lead to patient harm, and actually 80% of these reported errors involve the patient harm, which is very unfortunate. So what are the contributing risks that we can understand? Why are we having these patient harms? So here, drawing on a study from the Joint Commission report that evaluated 120 EHR-related events, we can see that the 33% of these errors have been attributed to the usability issues within the EHRs. And drawing on the analogy of the Swiss cheese model, as we see on the slide, we can think about these holes within the Swiss cheese from the policies and procedures, workflow and the communication, and the usability and actions. So one way to think about it, the biggest hole in the Swiss cheese model is at the level of the usability, perhaps asking us to do some proactive work of how could we improve the usability to improve providers' performance. So the specific aims of our study. What we try to do in a laboratory setting is to study the effect of 2 EMR environments. The baseline, the one that we currently use here in our medical center at UNC, and enhanced environment, as well as the volume of abnormal test results. And when I say the volume, please imagine your interaction with email on a daily basis, and how your strategies and interaction changes based on having little email to deal versus you have a lot of emails. So the effect of high and low volume is of our interest, as it can affect providers' experience, task demands, workload, and performance. And the focus in this study was on the abnormal test results, and as I mentioned before, the baseline and enhanced EMR environment used for the study was EPIC. So why do we do this? Some background and significance on the problem. Clinicians failed to acknowledge over 1/3 of the EHR alerts for critically abnormal imaging studies. Even when the providers do acknowledge, 7 to 10% of patients having abnormal results do not receive timely follow-up, and the likelihood of the timely follow-up doubles when providers use dual alert communications, or in other words, when they cross-cover for each other, due to potential troubles, personal issues, and so forth. So this is a picture of our laboratory. At the left bottom corner, what you can see here is our control room where we would set the experiment. We will have our computers. There's a one-way mirror that we can see into our laboratory where we would set up a station, and we'll bring our participants, trying to create an environment similar to the in a real clinic, and we will ask participants to conduct our scenarios. We have a variety of technologies and EMRs and EHRs that we could study and perform this type of a work. So study participants, we had a total of 38 residents from the School of Medicine in our academic institution to participate. You can see the table, the breakdown. Most of the participants came from the internal medicine. There was about 14 of them. The breakdown by the graduate year, there was a variety from different years, female versus male. One requirement to be able to participate in our study was the experience with using in-basket in EPIC, meaning being able to perform the task with evaluating normal and abnormal test results and being able to order appropriate tests or referrals. The way we designed the study, we would randomize the participants to either low versus high volume of abnormal test results. In a session 1, they would come into our environment, have a practice session where they could get familiarize themselves with the environment and what we are asking them to do. They would perform some of the tasks and recognize the abnormal test results. And in a session 2, where we, in a phase 1, we conducted all the evaluations on the current EPIC environment, and in the second phase, we conducted the evaluations of the enhanced EPIC environment. Participants would come back to our laboratory, were asked to recognize the abnormal test results, and also in this case, track and follow up on planned diagnostic evaluations of the subjects experienced during session 1. To give you a little bit more sense about the experimental design, what we refer to low versus high volume in this case, all our sessions included 35 results, and the difference of low versus high volume really refers to our abnormal test results. So in the low volume scenarios, we would have 8 abnormal results and 27 normals, and we would double that for the high volume of abnormal test results. That was in session 1. And in session 2, we would then continue to have the same total number of results. And in this case, what we've done, we had, again, 8 abnormals, but in this case, there were 4 patients that had a no-show status, so did not show up for a clinic where they were referred. And then we had 4 abnormal results. And in our high volume, again, what happens here, we double this experiment, except seeing some technical difficulties. We were not able to pull 8 patients and 3 results into the study, so left us really with 13 abnormal results in this case. Again, just to compare these 35 results, on average, the attendings would see about 50 to 60 results per interaction with EHR, with about 10 to 15 abnormal test results. So our experimental design for residents, knowing less experience with 35 seems reasonable. So, it took us quite a bit of work to be able to design this experiment. So this slide just represents kind of our sheets where we had to create master patients and be able to then upload these patients and all the results, the normal, the abnormal, which results are flagged versus not, and what we will expect from the participants' performance. And this itself, Amy Colchio, our UNC EPIC expert, presented this type of a design of how to accomplish this work at the EPIC conference last year in 2017. So we also kind of explain our procedures of designing this experiment. All right, so let's take a quick look, and I know this slide is maybe hard to read, but I just want to give you a glimpse at what the participants saw in the current EPIC design. So here you are in what you see is in basket, and this on here on the left-hand side we have all the results, right? And some of the results that are flagged with that little red exclamation mark. These are abnormal test results which can be sorted in the current environment, for example, for lab results. However, some of the other results that might be abnormal, like mammograms, which don't have the current ability to be flagged, are kind of placed somewhere on this list, and providers are asked to look through their list to be able to identify these, read, and then do a proper, to have a proper performance, right? On the right-hand side, we see a screen where some more details regarding the result is presented. And of course, the providers having different strategies would use one of these functionalities to perform their work moving forward. So let's take a quick look at the enhanced EPIC design. So according to the previous research and the recommendations of the scholars that investigated, and based on our own studies, we found that the two key elements for improvement that we initiated would be to organize all the abnormal test results into a specific folder. So you can see right here, now we have a folder with all reminders, and in this folder, all abnormal test results would be indicated. So that would decrease providers' workload in terms of looking through the list. And there is a functionality in EPIC to be able to capture all the abnormal test results and place them in these folders. So that's some of the functionality that already exists. So we could do this type of work to reduce that workload and task demands. And the second key improvement that we were testing, we were looking at utilizing the specific command lines here within the within this result node, to very quickly bring the situation awareness for the provider that this is a no-show, right? So that would be highlighted in right away for the provider, and at the same time also providing the provider with some to-do list, reschedule appointment in GYN oncology clinic, which could be based on the policy and procedures that could be established to make sure that the whole system works according to some level of standardization, right? So we were interested of the effect on performance, workload, and task demands that this enhancement would have on providers. All right. So how we collected our data. We looked at the experience task demands of the providers, and we collected clicks, and we divided them into navigation clicks, decision clicks, search clicks, and then we also looked at the total clicks. We also quantified the perceived workload, and we used the NASA TLX instrument, which is the widely and applied and valid tool for doing this. Here's a picture of the NASA TLX. You can see all providers at the end of the scenarios were asked to rate their workload based on the 6 dimensions, from mental workload, physical workload, temporal, performance, effort, and frustrations, and also would ask to perform pairwise comparisons to indicate which dimensions are more relevant, to this specific task, meaning that we would be able to have a weighting factor for the global NASA TLX score. The quantification of physiological workload was made based on eye tracking and EEG, and specifically we used the TOBI device, and also iWorks for data processing. We looked at the baseline measures, and we kind of went after very classic and validated measures for cognitive workload, which is the task-evoked pupillary response, TEPR, and a blink rate. And also from the EEG perspective, we use the X10 wireless EEG head system from Advanced Brain Monitoring, which uses a 9 bipolar sensor sites for this case. All right, and finally, the quantification of performance. We looked at the unacknowledged abnormal test results, which we identified based by failure to order a referral, medication, additional testing, and we also looked at unacknowledged patient with no-show status. which we were able to identify by failure to follow up with no-show patients. And we also took a measure of total time it took participants to complete each session. We did the multivariable analysis of variance. We did it at the pool data and at the abnormal versus no-show data. We treated participants as a random factor, and we were using JUMP 13 with a significance level of 0.05, and we were able to use, after testing, parametric analysis to conduct our analysis. All right, so just to place you, this is for the remaining of the slides. The format of my results will be in a table format. You will see on the left-hand side the data for the current EMR with the low volume. Then you have a current EMR with the high volume. This slide is representing results for the task demands. This is average per scenario. And on the right-hand side, you have enhanced EMR, low volume, and enhanced EMR, high volume. So all the results are presented here for your records. And some of these statistical differences we've seen. So at the pool data level, the only difference that we've noted in terms of clicks was that the high volume scenarios demanded more clicks than the low volume, which was expected by the experimental design. However, here we have not seen any significance, perhaps, to the improvement on the abnormal and no-shows. So going to the next slide, if we look at only the clicks it took to process abnormal versus no-show patients, here we see the improvement in reducing clicks. Specifically, for the enhanced EMR, we have less clicks, and most of the improvement comes for processing the no-shows. As we are increasing situation awareness for the providers, they are now not engaging in unnecessary tasks, potentially just reacting to abnormal results and trying to order a new referral. They would modify their strategies and then do the work that is needed at this case. So we had a significant effect here. When we look at the NASA TLX, we can only do it at the pool data, as the NASA TLX was only collected at the end of the whole scenario. We've seen no statistical differences between the enhanced and current or the volumes, which was to some degree surprising. However, we noted that in the current EMR with the high volume, where we had 16 abnormal test results, the average score of NASA TLX was 58, and there's literature, including ours, that when the global NASA TLX scores are above 55, we see these scores are associated with degradation in performance. The results for the physiological workload are quite interesting. So here we have potentially one of the first proofs that the enhancements in EMRs are producing physiological differences in the participants. Just if you look at the blink rate, which was significant, normally you can imagine that in normal conditions, when you do a very normal kind of a no-load work, you would blink about 20 to 25 times per minute. As you can see, the blinks were less in the current EMR, which would suggest higher mental workload in this case. So there was one proof that potentially we are seeing physiological differences between current and enhanced versions. Same thing if we look at the abnormal versus no-show results. We found that we had a significant differences in blink rate again, suggesting less physiological workload in the enhanced. And here at this level, we also noted the significant differences in EEG data, specifically the power of the frontal, your front of the head, power minus the power of the PZ, which is on the back of the head, which is a valid measure, of workload, which is also suggesting that participants in the enhanced EMR experience a more optimal information processing efficiency in this case. So that's very exciting to see these results. Finally, on the performance side, we had statistical differences in clinical performance. As you can see in the current EMR, missed abnormal results. We had a 2 and 6 in the low and high volume, and these things were reduced to 0 and 1 in the enhanced. And interestingly, the one missed abnormal test result was caused by the interruption in our laboratory, where participant engaging in the folder with those alerts got distracted while conducting the work. And as we know, being highlighting on the result would make the result go from bolded, just like our emails, to non-bolded. And after the distraction, participant directly went to engage with the next abnormal test results and not completing the work on the previous one. So that's kind of interesting. We also reduced the number of missed follow-up for no-shows. We can see from 15 and 17 to 2 and 4. Again, the 2 and 4 in the enhanced environment and some also in the current EMR were due to not understanding completely the policies and procedures of how to deal with no-shows. Some participants believe that that's not their job. Again, showing that the true improvement, the system improvement have to be done at all levels, as presented by Dr. Carayon. Also, if we look at the time, we only seen significant differences by volume when we, for the high volume scenarios versus low volume. But when we kind of break it down into abnormal and no-show results, we are seeing improvements, significant improvements in the enhanced version, again, reducing the time that participants spent mostly on the no-show results. So taking that into consideration as a whole, how much burden could we remove potentially using just these two enhancements, which are just scratching a surface, really, of what can be done in the EHRs to improve that performance. Again, if I just look at the enhanced EMR, there were 189 interactions or results processed with perfect performance, which were really done at about, on average, at 23 clicks, taking about 1 minute and 51 seconds. Just to kind of compare to the optimal performance within the current EMR, also 0 errors, were conducted with 32 clicks and 2 minutes and 27 seconds. So if we take the improvement, just comparing the perfect performance to be more kind of on the optimistic side, given 50 results, we are looking at reducing about 450 clicks and giving back to the providers about 30 minutes, which I think is very significant in this case. In conclusions, we need to really optimally design the features. We need to do this in laboratories. We have to roll it out incrementally, understand how this optimal design of the EHR can optimize providers' performance. We need to develop and make it public policies and guidelines regarding work practices and demands to ensure approved performance. But at the same time, we need to think about guidelines for levels of workload and performance, right? So we need to start thinking if it's okay for providers to interact with EHRs and processing class 50 plus results at the time. Perhaps we need to start taking a look at some of the guidelines of how this work should be achieved to ensure proper human performance. And also want to make a kind of a pitch that I believe it's really critical for us to look at the innovative education and training requirements so that the providers can learn about potential failures or potential system issues within the design so that they can be ready to engage in the real clinical environments. And one of the promising education training approaches would be a simulation-based training, and that's part of the work we are currently conducting in our laboratory. I want to wrap up in the last few minutes. This is a picture of my 2 boys. That is Sebastian and Alexander, 10 and 4. And this slide is really inspired by my supervisor, Dr. Larry Marks from radiation oncology. But if I had to now think of sending my boys to a hospital for a simple procedure versus putting them on the plane, I'm definitely much more anxious and nervous sending them to a hospital. And most importantly, I'm currently most afraid of not just the procedures, not the actual work that the providers are conducting, but being really frustrated to the degree that the errors that the providers can conduct would be during those interactions with electronic healthcare systems. So to some degree, I'm frustrated. I'm motivated to do better, and hope that we can accomplish this work in the next decade to optimize these issues. Our study has a number of limitations. This was still a relatively small number of participants. The sessions vary. The time between the sessions vary between 1 to 3 weeks. The day and time to conduct assessment varied. This was a simulated environment. The reporting workload through NASA TLX could be challenging for some subjects, and some of our methods for quantification of the physiological workload, could be subjected to some confounding factors. Therefore, to some degree, our results, are limited. Generalizability of our result is limited to some of these limitations. That's all from me. Thank you.
Thank you, Dr. Mazur, and that's a wonderful picture of your children, by the way. Thank you, and thank you all again for thank you again to all of our presenters for their very informative presentations. As a reminder, please submit any questions you have for our presenters using the Q&A panel. So, this goes ahead. This concludes the content portion of the webinar. Now we have a few minutes left for questions. I see a few questions coming from the Q&A panel, and I guess we can start from Dr. Carayon. The question is, how is the activity system defined within an organization? Does the definition or components of the activity system change substantially across organizations?
Well, thank you very much, Brian, for the question. So our system of defining activities was consistent across organizations, across hospitals, across services, as well as across phases of the VTE prophylaxis process, with the idea that we could define those activities at a level of abstraction that's high enough that we could do some of the comparisons. For instance, figuring out whether activities were primarily done with or without the EHR, and so that consistent set of activities across all of our different levels of analysis allowed us to do that.
Great. Thank you for that answer. Just a general reminder, we might not be able to get all the questions, but then we will put them all in writing and send the answers out to all attendees. This question is for Dr. Agha. Dr. Agha, how does gaze and paper chart physical exam compare? For example, compared to a non-automated office visit, did the doctor stare at the health records for the same duration as it were for EMR?
So that's a great question. Unfortunately, we don't have the opportunity to look at a completely paper-based electronic, a paper-based health record and compare it to an electronic health record. But I would rather say that comparison is somewhat moot, because we know there are so many advantages to the EMR in terms of decision support, increasing your ability to prescribe more accurate orders and prescriptions, that I wouldn't want to sort of turn the wheel back and say, well, should we go back to a paper-based system? But I think what's important is to study and evolve today's EMR and its user interface and functionality to a point where physicians are able to multitask efficiently and address their needs and their patients' needs.
Great. Thank you for the answer. And Dr. Mazur, so there's a comment about interruptions being so common in physicians' work. Are you going to pursue looking at error rates caused by this?
Again, that's a great question, and we have allowed in our experiments to make the environment more realistic. In our laboratory, we allowed for the interruptions, like, for example, pages, to see exactly how they affect. However, that was not our part of our main effect that we wanted to study. So a follow-up to this study, I think, is very reasonable to understand even further how the interruptions affect the interaction with the EHRs. And the one that I mentioned in my talk, what we found that could lead to some improvements is exactly that moment of bolded result, right? Switching from a bolded text to not bolded, which potentially, with the interruptions and the length of the interruption, could cause the problem like we've seen in our laboratory. However, the full exploration of what other risks are associated with interactions and the interaction with the EHR definitely should be studied, and we will try to do our best to perform additional studies to get at it.
Great. Thank you for the answer. I guess we have a few more minutes just for a quick question. Let's go back to Dr. Carayon. Dr. Carayon, how do you take into consideration personality and human behavior considerations for human factor engineering?
So thank you, Brian. I think that question was related to the data that I showed on the bubble graph, the survey data that had all those beautiful red and green and blue bubble graph. And the person who asked the question was making a really interesting comment that, nurses tend to say, well, it's more likely nurses that are responsible for this activity. And then same thing, pharmacists saying pharmacists, physicians saying physicians. We actually ask other questions about VTE prophylaxis, other activities, and we did not see that pattern consistently. So, for instance, when we ask about which group is best able to ensure that VTE prophylaxis is ordered, actually the pharmacists and the physicians who responded to the survey identified pharmacists as the group best able to address that aspect, ensuring that VTE prophylaxis is ordered. The answer of nurses was a little bit different, but really the point of those bubble graphs and looking at the different groups is to highlight that concept of role ambiguity. We really need to figure out how can we design teams and the entire system, including the technology, to help support those activities and clarify who's doing what, while at the same time taking advantage of the resilience of teams. And so that balance between role clarity and resilience, that second pair of eyes, is really important.
Great. Thank you for that great answer. We do have a few more questions for Dr. Agha and Mazur, but due to time, we'll just send the questions later and answer them in writing. So we have now reached the end of our webinar. Thank you all for attending. For those who are interested in obtaining continuing education credit for participating in this webinar, please visit the URLs shown on this slide. You will select today's webinar, which will be indicated by date and title, and then complete a brief evaluation of the event to claim your credits. You will have 60 days to claim your credit for participating in this webinar. Upon exiting today's webinar, AHRQ is also fielding a brief evaluation, and we hope that you complete the survey to share your feedback with us. Thank you all for participating in this webinar today, and we hope you join us in future learning opportunities.